You have leg pain and you're wondering, what is it? We do too. When you come in and see us and say your legs hurt, we're wondering what it is too.
Yeah, I don't love the vague leg pain kind of consult because it can be tricky.
But we put it in a framework that helps us figure it out.
Yes, break it down.
Welcome to Talking with Docs. I'm Dr. Paul Zalza.
Dr. Brad Wayne.
We're going to teach you how we approach leg pain so that you can approach it that way and maybe figure out yourself or get an idea of what's going on with your legs and why they hurt.
Yeah, and kind of with like 3 big categories. This certainly is not exhaustive, but this will capture most common things.
Yeah, this is going to capture the most common things. And at the end, then we have to remember just to talk about some red flags of things that, hey, if you have this and this, it doesn't quite fit in the category, it could be something bad.
Okay.
All right. So really the 3 main categories of why your legs can hurt can be something muscular or musculoskeletal.
Yep.
And I'm going to include arthritis in that.
Okay, I like that.
Arthritis of the hip or the knee or the ankle.
Okay.
Could it be a vascular problem?
Okay.
And in vascular, I'm going to include arteries or veins.
Okay.
So blood flow problem.
Yeah, because they're different.
Or 3, could it be neurogenic? Something wrong with the nerves.
Right, that could start from your back all the way right down to the tips of your toes.
That's it. The electrical system.
Okay, I like it.
Is it the electrical system, the plumbing system, or the machine, the lumber?
Okay, I like it.
Let's start with, what do you want to start with? Muscular?
Yeah.
Musculoskeletal, really?
Yes.
So, and that's the ones we're obviously as orthopedic surgeons most interested in because we have the skill set that might be able to help you, especially if it's an arthritis, okay? Talking about musculoskeletal. So if it's an arthritis in your hip or your knee,
Yep.
right? Where you're having localized pain in the hip, localized pain in the knee, or localized pain in the ankle or something like that if you have arthritis. And these pains are localized. They don't really travel. The hip arthritis, you can feel in your knee, okay?
Right.
And it can go down your thigh a little bit, but it doesn't go below the knee.
Ironically, it's often in the groin.
You feel it in the groin, right? Your knee pain doesn't go radiate distally or radiate proximally. It stays in the knee if it's an arthritis. Right. Same with the ankle pain. And if it's a muscle pain, it hurts when you push there.
Right, you can touch it.
Yeah, like your quads are sore, you push on your quads, that's where it hurts. Your calves are sore, you push on your calves, that's where it hurts.
Yeah, and this could be just from the aging degenerative process. It could be related to a specific injury. It could be related to overuse. Maybe you worked out really hard, that kind of stuff. So there's a whole bunch of potential causes.
And that's when you feel it. After a long day of work, then you feel it. After working out, then you feel these kinds of pains.
Yeah, depending on the cause, it could be sharp or dull.
Yeah, sharp or dull. It can feel like fatigue, tiredness in your legs. That's a musculoskeletal. That's a classic musculoskeletal type pain.
Right.
And then, so those are the symptoms. On examination, we'll move the joint, move your knee, move your hip. We'll push on the muscle groups to see if those hurt. And then we basically order an x-ray.
Yes.
That's the way we start. X-ray. Is there some arthritis in that hip? Is there some arthritis in that knee?
Or is there a fracture? Really, those are the 2 things we're mostly looking for.
All right. So that's your muscular pain.
Right. And this usually gets better with rest. I'd say most of the musculoskeletal stuff if you stop doing whatever you're doing that hurts, it usually gets better. And often will get better with time.
Stretching, massage, that can also help.
Okay, musculoskeletal.
Put that in the closet.
Okay, so number 2 is kind of the nervous system. So the nerves that feed our lower legs come from our spinal cord and then exit our spine through these tiny little holes, and then they trickle down the front and back of our legs. So this would include things like a herniated disc that's pushing on a nerve up top right at the spinal level. It could relate to a nerve that's being pinched at some point between its exit from the spinal cord all the way down to the tip of our feet.
Right.
And this can cause not only sensory problems, so abnormal sensation, but also can cause abnormal function, and also can cause pain. And the pain is different than their other kinds of pain.
But it still tricks you because remember, what's carrying this signal from our previous one that we talked about? Let's take it out of the closet here. The muscular pain, remember that one? Yeah. Well, how you feel that pain is the pain signals are carried through your nerves, right? So let's forget about the muscular pain now. Let's pretend there's nothing wrong with your muscles or your joints, but the nerves are irritated. Your brain can't tell. It's like, well, wait a minute, I'm getting the signal that there's pain coming from that area.
Right.
Because it's the nerve coming from that area that's being irritated in ways you mentioned, being pinched, squished, stretched, or something like that.
Right, and that can result in what kind of symptoms?
Now, those kind of symptoms are more electrical. You know what I mean? You can have some tingling, some numbness, some sharp shooting pains,
You'll say burning.
Burning pain.
Yeah.
Those are more nerve type pains that you can feel.
Yeah, and I'd say the other thing that can relate to this, not really on the pain side, but also this can cause a reduction in sensation or even muscular function. If the nerve is damaged enough, it prevents you from feeling normally or functioning normally.
Right. And now, why is it important to distinguish between nerve pain and muscular pain? Because the treatments are completely different, and the pathology that's causing the pain anatomically can be very far apart. It can be way up in your back for the nerve pain or way down in your foot for musculoskeletal pain, even though you feel. Now, nerve pain, unlike the muscular pain or musculoskeletal pain, it travels, okay? It can carry, you can feel it across a large difference. The classic one we think about is a sciatica, where you feel the pain starting in your buttock, going back down the back of your thigh, behind the knee, down your calf, into the outside of your foot.
Yeah.
Right? That is not a musculoskeletal type pain. That's a nerve pain that you're feeling.
And I'm sure it must be annoying when patients come and they're like, I got pain down here, and you're like, it's your back. You're like, what? It's not my back. I know no, that's your back. You're like, what do you mean? What is my back? And this is often worse with like coughing, sneezing, heavy lifting, or bending over, often relieved by position. So and would you do any investigations to help prove this? Does an X-ray prove it?
On physical exam, first we just, you can check the nerves, check your reflexes, see if they're working, check for sensation, see if that's intact, check for strength, see if that's intact, and then we go on to investigations. X-rays of the lower extremity,
always shows it,
where you're feeling normal, are going to be normal, okay? But if you look in the specific, usually with the back, if we start investigating your back, you're going to see there, you might see some arthritis in your back, some stenosis if you do some CT scans and things like that. Or if you do an MRI, you might see a disc pushing on a nerve or something like that.
And then if it even gets more advanced, you can do specific tests that look at either the sensation, like through a nerve conduction study, or whether an EMG, whether the muscle's receiving that nerve signal to function properly. These are more advanced tests for this kind of a problem.
Okay, so we've talked about musculoskeletal, we've talked about the nerve pain. What's left? The blood flow problem, okay?
Let's add some confusion.
All right, so now we're looking at let's talk about an arterial problem, okay? So arteries carry the blood away from your heart to your muscles. And if you have a problem with those arteries that aren't getting enough blood flow to your muscles will ache.
Right.
So it's kind of like an overlap because it is a muscular pain. But the reason for it is insufficient blood flow.
It's like a heart attack of your muscles.
Yeah, you feel a heart attack. So you're walking along and then all of a sudden, almost in a predictable distance, every time you get to this distance or this amount of time walking, your legs start to cramp up. And that's how people describe it. I get cramping feeling. Your legs start to cramp up. It hurts. You got to stop walking. You got to sit down. And then after you rest for a few minutes, it gets better again.
And they're like, I don't get it. Why is that? Well, it's because it's not that your leg has zero blood supply. So your leg has some blood supply, otherwise you would lose your leg. You would end up getting gangrene. Your leg would turn black and it would fall off. But when you're walking at a certain pace, if you go slowly, your body has enough blood supply to feed those muscles to keep you walking. But if you walk either at a pace that exceeds the supply rate or at a distance, this is commonly why people struggle with stairs, the amount of work that's done, the amount of blood supply that's required is exceeded, and that's when you get this what's claudication pain like you're talking about.
And you've all felt this. Anyone who goes to the gym and does a stationary bike, you've felt this. You turn the resistance up high, you're pedaling, and then your legs start to ache.
Right.
And that is just because you are demanding more from your muscles than your blood supply can supply.
Right.
The problem is when you feel that not on a stationary bike with it turned up to 18, when you're just walking down the stairs or walking down the street and you feel it. Because relatively speaking, your blood supply isn't matching the demands of the muscles at that time. And so we call it claudication, vascular claudication or neurogenic claudication. There's a few key differences between the nerve one. The nerve one can come on as you're walking, but it's a variable distance or variable time. The blood flow.
And the legs usually feel heavy and dead. They don't necessarily feel sore typically.
And the vascular one is almost the same at every time.
Right.
The vascular one, when you stop, a few minutes, the pain goes away.
Right.
The neurogenic one, you get the pain, you stop, and it takes a lot longer to go away because it's more of an inflammation of the nerve, and that process takes longer to settle down than just the blood flow coming back again.
Right.
And then there's also some nuances, like we used to be taught if you're walking up a hill, the vascular claudication is worse, but the neurogenic one's better because if it's coming from your back, you've opened up the spaces.
Postural,
right? If you're walking down a hill, your extension, you're squeezing the nerves a bit worse, so the neurogenic one comes on when you're walking down a hill. Walking down a hill, the vascular one doesn't really come on as much.
I like it. So that's the artery side, that's more on the pain side. If the veins are a problem, if they're causing a leg pain, usually it's more of a dull, aching pain, and it's because those veins don't work properly. The valves slowly start to fail as we age. You end up with pooling in your legs, so your legs feel heavy. They don't necessarily feel painful, but they can be very, very achy.
It can be phlebitis, you can have pain associated
Absolutely.
with it.
Yeah, so you could get a secondary infection or inflammation of those vessels in the skin around it. And you'll notice on physical exam, after people tell you this story, those legs look different. So a lot of people with vascular problems have less hair. They have abnormal changes in the skin. So if you're not getting enough blood supply, the leg might look whitish or look pale.
Yeah.
Whereas the venous side, if you have problems with your veins, often it can look a little bluish or a little grayish, or a little more swollen, or you physically can see the veins.
That's it. You can sometimes.
Yeah. Can we do any tests for these?
Okay.
X-ray?
Now if we're testing for the blood flow ones, again, yeah, we always start with an X-ray because that's an easy thing to do to rule out if it's a musculoskeletal and arthritis or something like that, or a fracture, like you said.
Sure.
But really, on physical exam, one of the first things you can check is, can you feel the pulses in your foot? You have pulses in your foot. You have one behind the inside of your ankle and one on the top of your foot. Those are two pulses that you can feel. If you can feel those, then yeah, there's a pretty decent blood flow going down there. If you can't feel those pulses, then no, there's not a pretty decent blood flow going down there.
Right.
That's probably the easiest test we do. But then we do other things where we look at the blood pressure in your ankles and your arm and look at the ratio. And from that, we can help determine if it's not enough blood flow down there. And then we can get into some fancy imaging of the blood flow.
Yeah, like even an angiogram where we put dye in just to see how open the tubes are that feed your lower legs.
Yeah, and those can help us distinguish if it's a vascular problem. You can see why this is so important. Because if it's a musculoskeletal problem, then you're going to come and see one of us. If it's a neurologic problem, then you're going to go see someone who deals in that area, like a neurosurgeon, spine surgeon. If it's a vascular problem, then you got to go see a vascular surgeon. Hopefully you don't never need surgery for any of these things, and you can treat these things the vast majority of the time without surgery, with some lifestyle modifications or medications, but at the end of the road, that's one of us that you're going to see.
You know what the worst part about all of it is, though?
What?
Lots of people have all three.
Yeah. Well, that's
so you see someone, you're like,
Yeah.
You got some arterial problem. I see you got some varicose veins.
Yeah.
You got some knee arthritis. You got a little bit of back arthritis, maybe mild sciatica.
Sure. Yeah.
And then the decision is, okay, well, what's the worst part?
Yeah.
And what are we going to start with?
And that's where it gets tricky.
Right? The back surgeons and the hip surgeons or the knee surgeons are like, no, you go first.
You go first.
Because maybe it'll get better.
Yeah. You go first. So yeah, but I think oftentimes if you have a nerve problem in the back, depends how severe it is. If you can deal with that,
can't rehab.
If it's very severe in the hip, so these are sort of some tricky things to try and work through. If you have multiple things going on, which one are you going to try and address first? But that's basically it. Like a simplification of how we approach people who come to see us with their leg pain. Is it musculoskeletal, sort of localized arthritis or muscles? Is it the nerves, or is it the blood flow?
Now you know. If you like this video, please like it, subscribe to our channel, share with someone that's got leg pain that they're not sure what the cause is.
And remember, you are in charge of your own health.
We'll see you next time.